Cognition and Perception. The cognitive perceptual health pattern deals with the ways people gain information from the environment and the way they interpret and use this information. Environment stimulates senses which pass stimuli onto the cerebral cortex. Perception is the collection, interpretation, and recognition of stimuli, while cognition is the intelligence, memory, language, and decision-making abilities. Sensory malfunction or malfunction in the brain will lead to disturbed perception and cognition. Visual changes we see with the older adult will include farsightedness. It's caused by a loss of elasticity of the lens, and it results in a decreased power of accommodation. And we call this condition presbyopia. It is a decreased ability to respond to changes in light and results in night blindness. We also see cataracts, which cloud the lens and result in blurred vision and a sensitivity to glare. With auditory changes, we see presbycusis, which is a loss of hearing acuity, particularly of higher-pitched sounds. Otosclerosis, which is that loss of hearing that results from decreased sound transmission, and tinnitus, which is ringing in the ears. Meniere disease, age-related changes, or medications can all cause tinnitus. Older adults are increasingly susceptible to misperception and therefore misinterpretation when one or more of these changes are present. People often talk about intelligent quotients or IQ when describing cognitive ability, but this is deceptive as there are different types of intelligence and standardized testing doesn't measure all the types. This type of intelligence takes place in the cerebral cortex of the brain, and each time stimuli are introduced to the brain, they're associated at an unconscious level with a pool of facts, memories, and experiences that are stored there. When these connections are firmly established, information is said to be learned, and after learning takes place, information or skills can be retrieved as needed. So we have fluid intelligence, which is the ability to perform tasks or make judgments based on unfamiliar stimuli. This is also called thinking on your feet, and nurses can often do this. Crystallized intelligence is also known as wisdom, and is the ability to perform tasks and make judgments based on the knowledge and experience acquired throughout a lifetime. It is a skill that's used more often by the older adult and can be difficult for younger people because they have less knowledge and experience. So using intelligence tests to describe cognitive ability can be deceptive, as a person with little formal education can still have high levels of cognition. Now, cognition is that ability to think and reason, and many people have good cognitive skills but score poorly on intelligence exams, which often measures those verbal and mathematic abilities, and they score poorly because they have limited education. Intelligence tests are also timed, which is not an accurate reflection as people process information at different speeds. Language is a product of cognitive function. We have sensory and cognitive problems resulting in poor language development or a loss of language skills. Damage to those language centers of the brain can result in aphasia, which results in an inability to understand or express language. Sensory problems, or vision, hearing, tasting, smelling, touch, sensation, can lead to confusion. A speed of information processing and recall will also change as we age. Intelligence does not automatically decrease with aging, nor does that ability to learn. Some people seem less intelligent as they age because of their tendency to be slower and more cautious in their responses. A lack of formal schooling can make older adults appear less intelligent, but many older adults ended their formal education at a young age because they had to work to help support their family. Advanced education was not a requirement for most jobs. Now, there's some degree of forgetfulness or memory loss common with aging. The short-term memory is going to be affected more often than the long-term memory. Many older adults begin to fear that they're losing their minds or developing a serious problem. Even without formal education, many older persons are able to compensate for memory gaps by relying more on the large pool of experience gathered over a lifetime. And well-educated older adults will tend to retain a higher level of functioning. So, true or false? Cognition is the same as education. This will be false. So when we're looking at altered sensory perception, during the assessment, determine has the person mentioned any changes in the taste or smell of food? Can the person detect whether something is cold or warm? Can they feel whether something is smooth or rough? Do they have known vision problems such as glaucoma or macular degeneration, cataracts, or refractive errors? Do they see small details or shadows? Do they frequently trip over objects? Can they read? If not, why? If yes, can they read newsprint or only the headlines? How close to the television do they sit? Do they wear glasses? And if yes, are they single lens, bifocal, or trifocal? When was the person's vision last checked? Does the person respond when people speak to them at their normal volumes? Can they hear a whisper from someone behind or to the side of them, or someone that cannot be seen? Do they turn the volume of the television or radio to a very loud level? Does the person turn his head to hear? Do they wear a hearing aid? Can they respond appropriately or inappropriately to question? And can they follow directions? Goals are going to be for the client to remain free from injury, to demonstrate improved ability to detect changes in the environment, to interact appropriately with the environment, to demonstrate the ability to compensate for deficits by using prosthetic devices and alternative senses. Interventions include ensuring that all caregivers are aware of the person's sensory problems, making appropriate sensory contact before beginning care, determining the best methods for communication with older adults, modifying the environment to reduce risks, verify that prostheses such as eyeglasses and hearing aids are functional. And interventions specific to the home, we need to ensure that all caregivers are aware of the person's sensory problems, make appropriate sensory contact before beginning care, determining the best methods for communicating with older adults, modify the environment to reduce risks, and once again, verify that prostheses such as eyeglasses and hearing aids are functional. So with confusion, this is anything that damages or interferes with the normal function of the cerebral cortex and results in cognitive problems. These should be given immediate attention. Sensory misperception, physiologic factors, or emotional disorders need to be ruled out first. Confusion is a mental state that's characterized by disorientation regarding time, place, or person that leads to bewilderment, perplexity, lack of orderly thought, and the inability to choose or act decisively and perform activities of daily living. We may see acute confusion, chronic confusion, and memory impairment. With acute confusion, this is also called delirium, We see disturbances in cognition, attention, memory, and perception. It's usually caused by physiological processes that affect the autonomic nervous system, such as uncontrolled pain, infection, metabolic disturbances, vitamin deficiencies, uremia, hypoxia, hypercalcemia, endocrine imbalances, myocardial infarction, constipation, drug toxicity, and drug withdrawal. It has a rapid onset. Symptom severity will vary, but it's usually worse at night and generally disappears after the cause is treated. It does not respond well to reorientation, as that cause is usually physiologic. Idiopathic confusion is from an unknown cause. The assessment should include recent life changes, and it tends to affect memory and concentration. These adults will often be depressed, and their symptoms are going to include a loss of appetite, a loss of interest in activities, sleep pattern changes, agitation, worthless feelings, and guilt. They usually will respond well to reorientation and stress relieving interventions. It may be reversible. Dementia is a slow, insidious process that results in progressive loss of cognitive function. It's caused by a damage to that cerebral cortex. It's most commonly a result of disease conditions and is progressive and irreversible. These symptoms are going to include changes in memory, judgment, language, mathematic calculations, abstract reasoning, problem-solving ability, impulsive behavior, stupor, confusion, and disorientation. These clients are going to be at an increased potential for injury and personal neglect. In the early stages, the older adult will recognize that something's wrong and they're able to explain away their problems. But in the later stages, these clients begin to wander and have excessive emotional reactions, combative behaviors, suspiciousness, hallucinations or delusions, and they may not recognize even closest family or friends. When the symptoms are worse at night, we call this Sundown Syndrome. So with the assessment, does the client mention changes in memories? Does their family or significant others note memory changes? Does the person have difficulty remembering recent or remote events? Can the person grasp new ideas, or does he or she have difficulty with this? Can the person make appropriate informed decisions? Does the person find it difficult to learn new things? What helps them learn new things? What is their dominant language? Do they speak other languages? What is the person's language or vocabulary level? What is their educational level? How long is their attention span? Are there significant behavior changes or hypoactivity? Is the person restless, uncooperative, belligerent, angry, withdrawn, or threatening? Has the person experienced any delusions or hallucinations? Are there particular times of day when behavior is most noticeably different? Does the person have a history of stroke or other brain disease? Have there been any recent changes in medication or dosage? Are there any signs of infection? What is the level of hydration? Are they constipated? What is their oxygen saturation level? And what are the results of the mini-cog test? Goals are going to include keeping the client free from injury, assisting in activities of daily living to the highest level possible. We want the client to be able to do as much as they can for themselves, but know when to seek assistance when it's needed. Interventions include assessing behavior or admission and at regular intervals, providing assistive sensory devices, orienting that person to person, place, and time, and providing any other important situational information, but never force the issue. Provide a structured environment that ensures safety, yet enables the person to keep active as long as possible. Provide continuity. Administer psychotherapeutic medications as ordered and avoid the use of physical and chemical restraints. Structure participation in activities of daily living. Structure the environment to minimize disruption or avoid sudden changes of room or environment. In other words, when these clients go from one environment, such as a home environment, to a long-term care facility or to a hospital, it can increase the confusion. Develop a plan to deal with acting out behaviors. Use effective communication skills and consult with the family and multidisciplinary team. So in the home, specifically, help the family accept the diagnosis. Help them to adjust to the demands of providing care for a cognitively impaired older person. Provide emotional support and help the family identify coping strategies. Help them identify community resources. Help them make arrangements for institutional placement if it's necessary. Encourage them to plan for those end-of-life decisions. Use any appropriate interventions that are used in the institutional setting. People that experience cognitive or sensory changes often lose the ability to use their words and communicate effectively. Dysarthria is more than usual difficulty with speech articulation, and it's usually caused by neurologic damage. Aphasia is the most common language problem among older adults. There's different classifications of aphasia, such as receptive aphasia, and this is where there's difficulty understanding language. They may be unable to understand the spoken word, but they can understand the written word. But they may not be able to attach meaning to spoken words. And they may be able to understand single words, but not word groups or sentences. Expressive aphasia is where there's difficulty in expressing oneself. Broca aphasia, they can understand verbal and written language, but they cannot speak words fluently. Wernicke aphasia is where they can speak, but words don't make sense. A lot of times we call this word salad. Or global aphasia, where we have receptive and expressive skills that are both lost. A loss of language does not equate with loss of sensory or cognition abilities. So in other words, just because they cannot speak does not mean that they don't, or that they no longer have intellectual abilities. Excuse me. So during your assessment, determine if the person has any sensory limitations. Have they experienced any injury or surgery that altered their normal speech mechanisms? And does the person have a history of stroke or cerebrovascular disease? Goals include communicating needs with minimal frustration, demonstrating an increased ability to communicate needs and feelings, and expressing satisfaction with or acceptance of alternative methods of communication. Interventions include assessing the older adult's communication problems and abilities, identifying specific approaches that are effective for each person, document in the care plan the selected techniques that facilitate communication, explain effective communication techniques to family members and friends, teach verbally impaired older adults methods for their specific communicating needs, and consult with a speech therapist or pathologist to determine the most effective communication strategies. So the nursing process for pain. Physiologic or psychological distress can cause pain, and pain is subjective. Responses to pain will differ from person to person. Now, Cultures also teach pain expression differently. They may be stoic and quiet, or cry and yell and moan. While older adults are at an increase for pain because of an increased incidence of disease conditions, they often will deny pain for fear of becoming addicted to medications. And sometimes it's difficult to determine the presence of pain in confused adults. So we look for changes in body language, increased vital signs or level of orientation, agitation, and increased confusion can all be indicators of pain. Pain is an indicator that something is wrong in the body. So with our assessment, does the person complain of pain? Is the pain constant or intermittent? Where is it? How do they describe it? Does it interfere with their activities of daily living? Does anything help control it? Do they take any medication to help with it? Excuse me. Goals will include being able to report an improved comfort level or decrease in pain, verbalizing the ability to cope with pain, demonstrating techniques that provide relief from pain, and interventions include a thorough assessment of the nature and severity of the pain, providing comfort measures and avoiding actions that increase the pain, anticipating situations that are likely to cause pain, teaching non-pharmacological approaches to pain control, and administering medications as ordered. And specifically for home, excuse me, help older adults and their families develop a plan to cope with the pain and use any appropriate interventions that are used in the institutional setting. Question: agitated behaviors, which are often worse late in the day, are referred to as, this is C, Sundown Syndrome.